Just want to keep things running on time today since we have a lot of presentations. So our next two speakers are Dr. Rob Foster and Dr. Milan. I am sorry that I'm probably mispronouncing your last name, Milovanik. Are presenting up next. Dr. Milanovic is a board-certified small animal veterinary surgeon whose research and clinical focus is the treatment of locally invasive malignant tumors, including the assessment of surgical margins. And Dr. Foster is a professor in the Department of Pathobiology at the Ontario Veterinary College of the University of Guelph. While a generalist, one of his areas of interest is reproductive pathology. So gentlemen, feel free to take it away.
All right, well, thank you guys. First of all, I just want to thank all the attendees for attending and the Davis-Thompson Foundation for sponsoring this series. Really excited to be able to speak with you all today about fascial planes and surgical margins. And Dr. Foster and I are going to be co-presenting. So we'll kind of be alternating back and forth, and we look forward to hopefully a lively set of questions at the end as well. Okay, let's go next slide. Dr. Foster, I think you have the control of the, oh, there we go. So we just want to, yep, go ahead, Dr. Foster.
I just wanted to welcome everyone and say that we are quite happy to take questions. If you use the question and answer function, we'll deal with them during the question period afterwards. And I keep a monitor on it so that if there are questions that we can answer as we go, we'll certainly do so. But we'll basically do a tag team here. So if things get a little disjointed, we'll soon get on track. So having said that, as part of the margin evaluation guideline, that is the VCGP, or that is incorporated in that, both Milan and I are not the only ones involved. We are part of a number of authors involved. And in particular, I've got the list of names there: Paul, Fran, Taryn, Philip, Keith, Don, Andrew, and a special mention to Michelle O'Black. Michelle O'Black is a surgical oncologist. She's an oncological surgeon, and she will be part of the panelists this afternoon taking questions, as Milan unfortunately won't be available then. So we have some objectives when it comes to this presentation, and we're going to cover these not as specific points as we go through, but we intend to cover all of these components. This is not a complete set of objectives for the this whole area, but it's the ones that we're going to concentrate on, particularly the roles of the surgeon and the pathologist in margin evaluation. The information on a pathology report that is, particularly as it comes to margins, that is useful for optimal patient management. We want to contrast the different expectations and in some part the communications that occur. And there is a sea change in what is being taught in veterinary schools to what has been taught historically, particularly as it applies to margins. And I know the Ontario Veterinary College now, and has for quite a few years, taught about fascial planes, tissue barriers, compartments, and inking of margins. So these are all things that are coming through the pipe, and the practitioners hopefully will be more familiar with the way that margins are assessed. We're going to mention some of the challenges that are involved with margin evaluation, and in particular, determining adequate surgical margins. So the recommendations are to no longer use clean, complete, completely excised, but the thought and the process that goes through when clinicians evaluate pathology reports is to determine whether the margins are adequate. We'll also look at the dense tissue barriers and the fascial planes, and we'll concentrate on that in particular, and how that's used in determining whether margins are adequate. And as we go through, we'll also identify regions of research into margin assessment.
Great. So, I thought I would perhaps start here with just a clinical example patient to emphasize why margins are so important to clinicians. And so I'll just use as an example here this adorable little 12-year-old female spayed Labrador retriever who has been diagnosed cytologically with a mast cell tumor and was staged as stage 1. So a very promising, good surgical candidate. And if we did the surgery, and in that case, the biopsy histopathology results came back as either Patniak grade 2 or a cupule low, whichever your preference is. And, in that case, let's say in scenario A, we have our narrowest histologic tumor-free distance, or you could also consider that a microscopic tumor-free distance at its narrowest was 8 millimeters. In that case, the clinician is likely to interpret that and say, I believe that is adequate for achieving local tumor control. There's a low risk for recurrence or spread. And so we're going to recommend simply monitoring the surgical site. In another scenario, in scenario B, maybe in this case, our narrowest histologic tumor-free distance is 0, meaning we have tumor cells at the surgical margin, ideally the inked surgical margin. And in this case, we're going to interpret this and have a discussion with the owners about the risks of recurrence. Again, these are higher than if in scenario A. And so we're going to have a discussion about potentially considering more surgery or adjuvant radiation therapy. Depending on the part of the country you're in, this may add cost in the value of $3,000 to $10,000. It may involve anywhere from 1 to 18 more episodes of general anesthesia. And we have to give consideration to how the owner might process this information and contextualize this in the overall trajectory of their pet's health and future. And so you can see here, these are dramatically different outcomes for both the patient and the owner who dictates the management of their pet. And so that is an example of why the data that we extract from the pathology report is so important and has such a direct impact on the patient quality of life.
So one of the issues that has come up in discussions with pathologists is which margin, or when do we actually need to do margin evaluation? When is it required? And there are different schools of thought, and I'm not going to suggest which is the most appropriate for every situation, but I can tell you my approach. One of the approaches is when it's requested. And there are times when you will see on submission forms that they request margins. There's a school of thought that suggests that if the margin is inked, that indicates that there should be margin evaluation. I know that many commercial labs automatically ink margins on any specimen that arrives that is not inked. How about just doing it on neoplasms that are potentially or recognized to be infiltrative? And there tends to be a consensus that that's an essential area. How about neoplasms where the diagnosis or the name of the neoplasm suggests malignancy? Or should it be done on all curative intent surgeries? My personal approach is that I use it more frequently than it's probably required. And that's because habits are important things to develop. And I tend to do it on anything, any neoplasm, and on any situation where it could influence patient management.
And so along those lines, I think it's important for clinicians to communicate to the pathologist. And if that's not happening, the pathologists should be empowered to ask for this information. And one of those pieces of information is, what was the intent of surgery? What's the goal? What kind of surgical dose was used? And I realize some of this terminology may not be completely familiar to all of us, and so we'll have a slide or two in the future here that will cover that. But for example, if the surgeon's intent was diagnostic only, for example, they performed an incisional biopsy, in that case, it's clear that a margin evaluation is not required and arguably might even be considered inappropriate. On the other hand, a local control or curative intent surgery, typically performed via wide excision or a radical excision, perhaps even with removal of the regional lymph nodes, now we're going to be very interested in what the surgical margins are in that case. The final category is the marginal excision. It's kind of confusingly named, and again, we'll clarify this in a couple of slides. That's a little bit more of a gray zone. It really depends on what the goals were of surgery. Again, like Rob mentioned, I think the safest thing to do, if in doubt, evaluate the margins. It's never going to hurt. And so again, I've kind of implied this earlier, but the surgeon, or even just broadly speaking, the clinician, right? Medical oncologists, radiation oncologists, all of us, general practitioners, we really rely on the histology report as a critical piece of data. And the analogy I'm going to draw is, think about when we submit, clinicians submit a test of another nature, perhaps a serum biochemical profile or a CBC or whatever else, and they get that report back. Now it's their job to interpret that data in light of the entire clinical picture, right? Everything else they know about the patient. And then based on that, they take that information, that interpretation, and advise the owner and how they're going to proceed. So really, the histologic margins goal of a report should be to report that data as objectively and accurately as possible. I put a little asterisk there because we know that there are challenges to that, and we're going to get into that in just a second. But if we do our best, we really strive for excellence and uniformity in this, it will hopefully allow the clinician to decide if the surgical margin is adequate or not. And like Rob mentioned, we're trying to get away from the recommendation. Well, the recommendation is to not use subjective terminology such as clean or close or dirty, but rather simply report the more objective data of what is the narrowest histologic tumor-free distance, and ideally what the tissue that margin is comprised of. Again, in that case, we're providing critical data to the clinician who will then determine whether that is an adequate excision or not.
And I want to reiterate that having this data, regardless of the individual who submitted the sample, whether they be primary practice, whether they be secondary, tertiary practice situations, including this data will help with referrals and will get into the area where people are looking at whether something is adequate or not. There are lots of challenges, and we are all very much familiar with many of these challenges. This is not a complete list by any means. And these are areas, all of these areas are areas where things can be improved, where research can be done, where things can be optimized. We all know about how poor or incomplete some of the submission forms are. It's as though you're on a need-to-know basis and you don't need to know for some of the reports, and others are really good. I was quite surprised that in the human field, one of the pathologists' biggest issues was the lack of submission information, and that really surprised me. But it's widespread. We deal with it. That is a challenge. Sample handling and submission. This includes inking of margins, the whole fixation, handling situation, and then the technical situation in the laboratories. we face major financial limitations. Histopathology is a high volume, low profit situation, and we simply cannot do the 30 different slides that is standard for a 1 centimeter breast mass in humans. 1 slide per case, provides a profit. 2 slides per case, greatly reduced profit. And anything more than that is usually on the laboratory. There are lots of artifacts, and we'll mention some of these, shrinkage and distortion artifacts. The trimming methodology, and we're not going to get into trimming methodologies in particular. There are certain standards that are done, and it's challenging to be able to trim every submission in the way that will provide the data that's necessary. There are very large samples. How many samples should we be taking? We've got small slides. So that's a real challenge. And another challenge that labs have is that because it's a low profit, high volume situation, the number of cases that pathologists are expected to do can be quite horrendous in some situations. And if you're doing 60 cases and you provide the data for margins on a large percentage of those cases, you could be increasing the length of time you're spending per day by 30 minutes, an hour, maybe more sometimes. So that's a real challenge. And there's just too many to count of additional challenges that we have.
And so again, what do we do faced with all these challenges? And really it comes down to, if we just throw our hands in the air and give up, then we're not going to make any progress. Instead, we have to recognize that progress is made incrementally in situations like this and focus on diligent application of our methodology. And one of those things is really improving the communication between the clinicians and the pathologist. We've all heard the phrase garbage in, garbage out. And so along those lines, we want to tackle one of those topics today. We're going to focus on this concept of fascial planes, because it's come to our attention that, many times surgeons and pathologists may not know exactly what the other is referring to when we talk about fascial planes. So hopefully by the end of today, that's one of our objectives, is to have that cleared up a bit.
And I'd like to reiterate that. And if you spend some time talking to people who submit samples to you, you'll be surprised sometimes as a pathologist just what they interpret. So, for example, what a pathologist's interpretation of a clean margin is very different to what the clinician sees from that. Fascial planes and the whole talk about fascia and fascial planes is one major area, and we'll certainly be dealing with that.
And so, first, let's make sure we are all using some similar terminology. I'm a fan of referencing established published literature, even when it's imperfect, just because it ensures that we're all using the same terminology. So, Rob, if you'll click, that's our little green tumor. And we've taken a little wedge out of that, perhaps with a scalpel, perhaps with a true cut instrument, perhaps with a punch biopsy, whatever. If we're taking a little piece of it, that surgical dose is categorized according to Enneking categorization as incisional biopsy, okay? Alternatively, we might just trace the very edges of the grossly visible disease, and that's going to be called an excisional biopsy, confusingly also called a marginal excision. So that's a really important one. I want to emphasize that a marginal excision is the same as an excisional biopsy, does not involve trying to get a wide margin of tissue. And that leads me to the next example of the surgical dose. If we do take a wide excision all the way around, we're going to incorporate grossly normal tissue, because we anticipate that based on our preoperative diagnostics that this tumor type is going to invade microscopically into those tissues that we cannot appreciate grossly at the time of surgery. We're going to remove a rim of tissue. That's going to be called a wide excision. The one thing I'll tell you about that is a wide excision is going to vary depending on the tumor type that you're dealing with, arguably the grade, sometimes the patient signalment, all those factors are going to impact how wide of a wide excision you do. I put some examples down there. For example, a mast cell tumor, soft tissue sarcoma, many people default to kind of that 2 to 3 centimeter rule. Whether that's perfect or not is debatable, but what's not debatable is that things like a feline injection site sarcoma is going to be far more biologically aggressive, more microscopic invasion into the surrounding tissue, and is going to justify a larger surgical dose. So in that case, a wide excision may be upwards of 5 centimeters and 2 fascial planes deep as opposed to just 1. Really important here again is not just the quantity, but also the quality of that margin. There is the general concept, and we're going to get into this more here as we talk about fascial planes, that certain anatomic tissues provide more of a barrier, more of a naturally occurring barrier to tumor invasion. For example, I think that if we all conceptualize a piece of solid cortical bone, we can agree that the tumor is not going to invade that as readily as it would loose subcutaneous fat, for example. And so again, that's where reporting that objective piece of information, what is that margin comprised of, is critical piece of data to the interpretation of the adequacy of those surgical margins. And then finally, the largest surgical dose would be called a radical excision. And if you think about a complete mastectomy or an amputation, removing the entire compartment, that's a radical excision.
And yeah, part of the recommendations in terms of reporting of margins is based on the fact that there is so much variation between tumor types and what is considered an adequate margin. What we see as microscopic, a histologic free distance of perhaps 1 millimeter, that many pathologists would consider to be a complete excision, for some of these entities is not a complete excision at all. It's not adequate. And so when it comes then to looking at margins, having an idea of the surgical dose will really help. And it would really help if our submission forms actually included something that indicated what the surgical dose was going to be. So this brings us to a discussion of what is essentially a surgical consideration, and that is tumors grow in compartments. That compartment may have a specific surrounding boundary. Others compartments do not. And tumors are expected to grow within a particular tumor compartment, and they grow where they arise. The goal is to remove the entire tissue compartment containing the tumor. So when it comes to reporting margins, knowing if it is growing in a compartment, then will drive the data that you provide. Now, there are some locations where there is not a robust tissue boundary, and I'll provide some examples coming up. This boundary then becomes a potential barrier to spread of a tumor.
I can just add to that briefly to just say that you may encounter individuals who want to differentiate in sort of a binary manner a compartmental resection from the classic Enneking categories of surgical dose. Actually, that division is mostly artificial. The reality is, if you think of it, a compartmental resection is compatible with the goal of a curative intent or wide Enneking excision, because essentially you're recognizing that there are these certain anatomic barriers, or at least anatomic structures that are less likely to be invaded by the tumor, and you're leveraging that reality in order to achieve a excision that hopefully will not have tumor cells at your surgical margin.
So what is a compartment boundary? I would hope that most people would have heard of the compartment idea, but for those who haven't, and as a refresher, what is a compartment boundary? It is an anatomic or histologic tissue barrier, usually composed of dense collagen or other dense connective tissue, that is anticipated to limit tumor spread. And this is the structure that surgeons refer to as a fascial plane. So a fascial plane is not fascia. A fascial plane is a boundary that is thought to limit or believed to limit tumor spread. For example, the epimysium of skeletal muscle is a fascial plane. It is a compartment boundary. And when you do margin assessment, the expectation is that you will describe what you see and you will provide the data that includes this compartment boundary and the relationship of the tumor to the compartment boundary, the relationship to what is called a fascial plane. And I've got an example here that I took. This is an MRI of a dog that had a swelling on its hind leg. And the image on the left, this is the T1 weighted image. And I think most of us can recognize that there is a mass here that involves the muscle. And this is a very well circumscribed mass. And this mass is growing within a muscle. And based on cytology, it was diagnosed as an intramuscular mast cell tumor. On the right here, I particularly like the T2 post-contrast MRs. And so this is a T2 post-contrast. And it shows the well-defined nature of this mast cell tumor and some of the other changes that occur around this muscle and tumor. So this mast cell tumor is growing within a muscle. And the aim of surgery is for local control, preferably curative. And so the curative intent surgery in this case is to take the muscle out, is to remove the muscle. And when you remove the muscle, then when it is sent for biopsy, not only do we confirm the diagnosis, but we also, most importantly, supply the data of that compartment boundary, of that fascial plane, and that would be the epimysium of that muscle. So in this circumstance, we took multiple samples through this muscle and we reported the relationship of the neoplastic cells to the compartment boundary. Now, in this case, the distance from neoplastic cells to the surgical margin was minuscule, less than 1 millimeter. But from what we could tell, there was a complete compartment boundary, a complete fascial plane around this. And so this, when looked upon by the surgeon, was considered an adequate excision. And so there was no need to do 2 centimeter margins. It was restricted to the muscle. So what are the defined compartment boundaries and the defined compartments? Those areas where there is a complete boundary is a muscle belly. So intramuscular tumors in those muscles that have a defined epimysium, that is a compartment, and the epimysium is the boundary. Bone, both the cortical bone and the cartilage provides a barrier, or if a neoplasm is osteolytic, then the periosteum will be this dense tissue barrier that is the compartment barrier. Within the joint, it would be the joint capsule. Many of the organs in the body have a capsule that completely surrounds that organ, the kidney, the adrenal, the thyroid, spleen, and gonads. And so describing relationship of neoplastic cells to the capsule then becomes important in determining whether that excision was adequate. In the nervous system, it's the dura, which is a really tough and obvious dense tissue barrier. And then the bone of, say, the skull or the spine, and the epineurium, particularly of peripheral nerves.
And I'll just add in one clinical example here to demonstrate on one of these points that Rob was talking about. If we think about the scenario of hemangiosarcoma in the spleen, we recognize that the capsule in the spleen is physically less robust than many of the, for example, epimysium surrounding muscles or even more cortical bone. Yet, it does provide some degree of encapsulation and resistance to tumor spread on a local level. So we know that hemangiosarcoma, for example, is very prone to spread to distant organs, liver, lungs, etc., which is via the hematogenous route. On the other hand, we know that in terms of local extension, for example, to the omentum, is very unlikely as long as the splenic capsule has not yet been ruptured. So when we find cases of hemangiosarcoma in their early stages, we're likely not going to see omental direct seeding of hemangiosarcoma. On the other hand, those cases that have undergone splenic capsular rupture and thereby invasion into the peritoneal cavity, directly seeding the area, we often do find omental hemangiosarcoma lesions. And the same is true for other endocrine organs, where that capsule integrity is important in terms of determining the adequacy of the local excision, independent of the risk for distant metastasis.
There are lots of samples that pathologists receive that come from compartments that do not have complete boundaries. And these include the skin and subcutis, the tubular organs, the intestine, for example, reproductive tract, lobes of the liver and lobes of the lung. These, because you do a lobectomy in a lung, there is an incomplete compartment boundary. So reporting then includes the distance to that surgical margin, but also relationship to the compartment boundary. Now, what are the boundaries in skin or subcutis? Well, there's a couple of potential boundaries. The one that is particularly relied on is the epimysium of any deep muscle. And we will see examples of that coming up very shortly. There's also the subcutaneous striated muscle, which may or may not be an appropriate boundary, but it's one that if you're aware of, you can report. In internal organs, for example, the intestine, the reproductive tract, the muscularis mucosa, the mucosal muscle as it's officially termed, the muscular zone, the myometrium, the tunica muscularis in Latin, and the serosa are potential boundaries. So there are some tumors where prognosis does depend on how deep there is invasion, for example, in malignancies. And it's particularly important that you do histologic tumor-free distance. That is the distance from neoplastic cells to an inked margin. And that becomes particularly important when there is no boundary or barrier, or if the neoplasm has breached or violated a boundary. Let me show you histology, because we are a bunch of pathologists, most of us, and we appreciate looking at blue and pink on slides. So this is a case that I looked at not long ago. This was a feline mamma. For those of you who think that I've made a mistake in spelling here, mamma is the mammary unit in cats. They have 8 of them, and each is composed of multiple mammary glands. So this is a sample. This was a mastectomy sample, and you can see here that there is mammary tissue and there's neoplasm growing within the mammary duct. This one happened to have a papillary intraductal or an intraductal papillary adenocarcinoma. And in this case, the specialist surgeon did a mastectomy and removed abdominal muscle wall. And in this circumstance, the fascial plane, the dense tissue barrier, is actually the epimysium. Now, it's not very thick here, but yet this is a potential barrier, and this is what the surgeon aimed for. The muscle here, you see it has lots of spaces between individual parts of the muscle. Once that fascial plane is breached, then it's fairly easy for that tumor to invade between those muscle bundles. So this is actually the fascial plane that they're looking at. And this was the one that I reported on. I took this particular sample because it was at the edge, so we can see the difference in contraction. Striated muscle contracts a lot more. There is actually an inked margin here. And then we have skin. So when I reported this one, I reported the compartment boundary, which is this epimysium here. And then I measured from the neoplastic cells to the surgical margin, and that's the histologic tumor-free distance.
That's a really great slide, Rob. And I'm just going to interject here briefly because we're about to see some intraoperative images in the next few slides that this can correlate to, although it's a different tumor example. So I'll just point out again, emphasizing that here we have an incomplete boundary, if you think about it from a full 360-degree spherical approach, right? Within the subcutaneous tissues, that's not a good fascial plane. And so that is where the surgeon then measured out some distance and performed a wide excision, right? And they did that because they expected exactly what we see on this slide, that this tumor is expanding within that tissue plane, within that tissue compartment quite readily. On the other hand, in the deep margin, so deeper towards the central axial level of the body, there is a fascial plane that can be leveraged, and that's that epimysium. And so although it's not a complete compartmental excision, there is still leveraging of the knowledge of compartmental tumor growth in order to provide a hopefully adequate excision in this case. And so although the histologic tumor-free distance, if measured towards the deep direction, is going to be quite a bit shorter in this case than it is if measured to the viewer's left on the circumferential margin, it's still likely to be judged as adequate because of the presence of that uninvolved, uninvaded fascial plane.
Here's another example. And this one here is the subcutaneous striated muscle. For those of you who haven't heard of it, this is the official histological term for this muscle. It's located in the subcutus. That's why it's called subcutaneous. It's striated. It's not actually skeletal because it doesn't attach to the skeleton. And anatomically, this is called the cutaneous muscle of the trunk, or the platysma muscle. Both of these muscles form part of the subcutaneous striated muscle. The naming for the anatomical structure is different to the histological structure, simply because it's historical mostly. This particular muscle varies greatly in the type of tissue that surrounds it. So its epimysium can be very thick. It can be non-existent. It can be on both sides, as you see here, or it can be just on one side. And this here happens to be a dermal mast cell tumor. It's growing in the skin. And in this particular case, it invaded into the subcutus, and you could see histologically how it came upon this barrier and then it moved sideways. So this barrier here that I saw histologically then became a compartment barrier for that mass. And so I reported this as a potential compartment boundary or fascial plane. This can't be relied on because it varies in different locations through the body. So you have to know a little bit about the anatomy of the location to know which compartment boundary you report.
Great. So this kind of gets into surgical planning. You can see that we've talked about various features, anatomic features primarily within the body. And so surgeons are going to have to plan, and for that matter, radiation oncologists similarly are going to have to plan their treatment plan around the anticipated biological behavior, which requires a preoperative diagnosis. And so in the absence of that, that would be called an unplanned excision, which is generally strongly discouraged. We have to leverage our knowledge of the expected compartment tissue barriers, as well as other things like preoperative staging and comorbidities to decide what surgical dose we're going to administer, and then hopefully communicate that. It can be very brief, but still potent in our pathology request form. And so, again, what we're looking for on the pathology report is the relationship to the surrounding tissues of the tumor relative to those other tissues, the presence of tissue barriers to invasion, whether they have been violated or whether they are preserved and intact. Again, these are typically what we would call fascial planes. And then ultimately the histologic tumor-free distance on that slide. So we're going to walk through an example of a planned surgical excision. This is a dog with a subcutaneous cytologically diagnosed soft tissue tumor or soft tissue sarcoma. You can decide which term you prefer. It ended up being specifically a hemangiopericytoma or perivascular wall tumor, again, depending on your specific leanings there. Those group of tumors, we know preoperatively, we anticipated them to have a locally invasive behavior pattern, but a low risk for distant metastasis. And so the image here is labeled in the directions dorsal ventral cranial caudal. So we're kind of over the left lateral thorax. The tumor itself has been cross-hatched with a sterile surgical marking pen. The hair is shaved and we're draped off ready for surgery. The proposed skin incision, which is a wide excision, has been drawn in solid ink all the way around it. You can see in the bottom left, maybe I could have made that a bit more circular in nature, but it conveys the goal of a wide surgical excision. So just some more preoperative staging information. The local lymph node was evaluated for metastasis and was determined to be reactive, and the thoracic radiographs were normal. So again, this is our preoperative staging. So now we know it. We don't have any evidence of spread. It justifies putting the patient through a surgery, spending the owner's money, and attempting to get curative intent local control via a wide excision. There we are. Okay, at this point now, we've just cut through the skin. You can see that the elastic properties of the skin have resulted in a gap, which is far wider than the width of the scalpel blade. We've also dissected the subcutaneous tissue pretty much along the same line, straight down deep towards the fascial plane. And now we've encountered what a surgeon would simply say, I've come to the fascial plane. Great, what are we talking about? Again, that is the epimysium. In this case, the lateral aspect of the epimysium of the latissimus dorsi muscle. Based on my preoperative CT scan, I knew that this tumor did not seem to even contact that epimysium. And so, at least grossly, from what I could see on the CT. And so I plan to remove that epimysium en bloc as a single unit to act as my deep fascial plane, or my deep anatomic barrier to tumor invasion, and hopefully prevent any sort of tumor cells from being found at the surgical margin.
So I'll just something for the pathologist here. The term for that epimysium is fascial plane. It is different to what we understand as pathologists as fascia, because fascia includes interlobular septa. It includes the fascia in between muscle bundles. It allows movement of skin. So I would advise people not use fascial plane as a histological descriptor, but rather consider fascial plane as this term that is used by the surgeons for those compartment boundaries. So our concept of fascia is different to what is a fascial plane. And that's why we've got it in inverted commas, but you will just simply see it on submission forms as fascial plane.
Okay, and then this is just showing a stepwise procedure, starting to excise that fascial plane. Now, if I was perhaps a more skilled surgeon, I could have used a scalpel or electroscalpel and split the thickness of this relatively thin muscle. Why did I choose not to do that? Well, I was not confident in my ability to fillet that muscle split thickness, let's say half of its thickness, without potentially accidentally violating the more superficial, the more lateral aspect of the epimysium, which would have then destroyed my ability or hampered my ability to remove the deep margin with an intact fascial plane. So in this case, I judged the morbidity of a full thickness resection to be low, and I wanted to maximize my chances of having an intact, complete barrier to tumor invasion on the deep aspect. So I chose to do a full thickness resection. And the next slide will show the intact deep margin here that has been inked blue to call attention to the pathologist to please evaluate that deep margin for intactness or any potential defects in that as well, or tumor invasion. The circumferential margins have also been inked individual colors to help with orientation of the specimen and also facilitate identification of the surgical margin as opposed to any margins generated artifactually through trimming. So those are sort of the main things I was thinking about as I inked this. For some of you who may be looking a little more astutely, you may notice that there are some sutures in certain areas as well. For example, the yellow inked margin has 2 suture tags. The black inked margin towards the bottom of the screen just has 1 suture tag. These are basically also used as directional markers. There are some good papers by Maria Risalada you can look up about suturing the tissues that you are submitting and the impact that may have on distortion in particular. The bottom line there is that although suturing circumferentially, fully, like a continuous pattern, prevents some of the torsional deformities, it does not affect things like shrinkage. Additionally, for me, I often am hesitant to suture extensively because I worry that I'm introducing ex vivo artifacts that may actually complicate the pathologist's interpretation further, because I recognize the potential for these specimens to fix in formalin in awkward positions that are not representative of the in vivo configuration of tissues, which then makes the assessment of margins more difficult. Okay, just a quick note here. We've been using this term surgical margins sort of loosely. I just want to emphasize that surgical margins undergo an evolution that's related to the time from intraoperative excision all the way through to where they show up on a glass slide. So certainly the intraoperative gross surgical margin is the tumor-free margin that we're measuring intraoperatively, as you've seen in these pictures. And then there's the post-fixation, which is still a macroscopically normal margin. You could argue that even when it gets on the slide, you could just look at that with your naked eye and identify a subgross margin length. And then finally, when you put that slide under the microscope, you're going to see a histologically microscopic tumor-free distance.
So just a summary of what we have covered, and then we'll get on to questions. And I see there are some questions in the Q&A section here. So what have we dealt with? It's important that the pathology report indicates the relationship of neoplasm to surrounding tissues. Is it invasive? Is it not invasive? Does it have compressed collagen or a capsule or not? What are the compartment boundaries, and if appropriate, which dense tissue barrier is there, and what's the relationship of the neoplasm to that fascial plane? And what is the histologic tumor-free distance? I noticed one of the questions is about reporting, how do you report that? Do you go down into parts of a millimeter? The recommendation is that the general consensus was that going less than 1 millimeter isn't really a benefit unless there is supporting documentation to suggest there is. So, how you report it, we're very good at determining very, small distances. I would suggest that if it's important, then you go for smaller distances than just 1 millimeter. But in general, 1 millimeter, was the consensus. If there is no complete or defined compartment barrier in that location, then you report on what you see. And if you see a compartment boundary, a potential boundary there, then report it. It is the surgeon who can assess adequacy of excision. They have all of the information that is required. How fast this is growing, exact location, relationship to sensitive structures, what their surgical dose was, and what their overall aim was. And if you use clean, close, or complete, many clinicians, certainly the ones that I've spoken with, who do an unplanned surgery, take that as meaning adequate. Whereas we see a gap, a space, a histologic tumor-free distance, it may not be adequate. And by saying it's complete, by saying it's clean, they are interpreting that as adequate. So the recommendation is that unless you have all of the information required to make that determination, it's best to report the data and any peer-reviewed literature information that there is on that particular entity, and provide guidance based on peer-reviewed literature.
Absolutely. I'll just throw another clinical example in briefly. I know we're basically out of time, but let's say we find a narrowest histologic tumor-free distance in 2, 3, or even 4 millimeters. Well, at face value, that could look like an adequate excision if that's all I tell you about the case. But if I add to that it's a high-grade mast cell tumor, we're going to be more suspicious that that may not be adequate for that particular patient. On the other hand, again, if it's a low-grade soft tissue sarcoma, let's say, that is likely to be interpreted as adequate. So again, it's the clinician's job, surgeon, medical oncologist, general practitioner, whoever, to interpret that information in light of the clinical context and make a final determination on the adequacy of excision.
Okay, so we would like to acknowledge various people, and Milan, I'll let you acknowledge your group first, and then mine. Just
briefly, I want to say thank you to many people beyond the people on this list, but there's a team at Oregon State University that I've worked with over the last 10 years that has been really critical. And so Dr. Duncan Russell in pathology and Dr. Lohr in pathology, Dr. Katie Townsend, who's a surgeon, Dr. Katie Curran and Haley Leeper as medical oncologists, and the rest of the oncology team have really been pivotal in helping me understand some of the challenges that we face and the opportunities for improvement from those challenges.
And I'd like to thank the oncology team at the OVC, Ontario Veterinary College, particularly the surgical oncologist, Michelle O'Black, who you will meet this afternoon. Val Poirier is our radiation oncologist. Paul Woods is medical oncologist. And there are many others, medical oncologists, as well as the graduate students in both pathobiology and in clinical studies, and those particularly involved in oncology and surgery and others. And of course, the Davis-Thompson Foundation and the ACVP for sponsoring this webinar. There are some questions here, and I'd like to deal with that, with those now. One of them I've dealt with, and that is, do you report less than 1 millimeter or fractions of a millimeter? So if it is potentially important, then I'll go fractions of a millimeter. Otherwise, the recommendation is to round. Do I consider the panniculus muscle an appropriate term? I use Nomen Histologic of Veterinaria for histological terms, and the official Nomen Histologic of Veterinaria name is subcutaneous striated muscle, so that's what I use. And one for you, Milan. As a surgeon, does it matter to you which lateral margin is which in histological analysis? I have seen some pathologists specify which lateral margin is which in their report, and others just specify lateral versus deep margins as the lateral margins are joined at closure.
Yep. So generally the rule of thumb is if any margin has neoplastic cells touching ink or at the surgical margin, the entire surgical bed is considered potentially dirty. And that's because you've potentially seeded the entire surgical bed with tumor cells. Now, that said, obtaining information about which specific direction, cranial, caudal, whatever, whichever surgical margin is dirty, if there's a specific one that is, or just use the term dirty, has neoplastic cells touching the surgical margin, that's very useful information. If nothing else, it helps the surgeon plan his or her future surgeries. It's almost like feedback. How did they do? But also, in some cases, it can be used to address the incomplete excision, the inadequate excision that has been determined by the clinician. So they might say, well, okay, I know that in this particular direction, the tumor cells were touching our surgical margin, and so I anticipate there to be more disease, perhaps in that direction. That's a bit subjective. I don't know of any data that has proven that to be the case. Logically, it certainly makes sense, and some people do treat that accordingly. So again, it's never wrong to provide more detailed data in your reports. That said, the rule of thumb is that, again, if one surgical margin is contaminated with tumor cells, the entire wound bed is treated as such.
And there's one more question here. How should tissue submitted from a surgery to get wider margins be handled, as there will be artifacts of tissue healing, suture reaction, etc.? I can answer that with the approach that I take and that we take. And then Milana, if you want to comment. So basically, the important thing is the distance between any previous surgical site and the new surgical margin. So in many respects, it doesn't matter if there is residual tumor there. It is the margin that is being looked for in that subsequent surgery. So I report the distance between the previous surgical site and the new surgical margin. And the other thing I'll say is that in some circumstances, surgeons will change their pack, the surgical pack, and they will use separate instruments for a different area, and they will usually indicate that on the submission form, and that should automatically flag you to be specific about the particular margins that they are interested in.
Yep, exactly. I'll just add to that typically when surgeons plan scar revision or a reoperation on an inadequately excised tumor, we're going to still take a grossly normal surgical margin. So if you imagine a wide excision drawn around the prior surgical scar and any palpable disease, any grossly palpable disease, we're going to measure a margin around that and excise it. And so again, what we're looking at here is what is our histologic tumor-free distance from our new surgical margin to any existing microscopic disease. If it's overtly neoplastic, great. If it's even questionable, please report that as well, because as we know, low-grade soft tissue sarcoma is difficult to differentiate from, reactive scar tissue, things like that. But again, if you see any abnormal lesions, whatever they are, please report the minimum distance between those lesions and the new surgical margin, which is hopefully going to be considered adequate.
Okay, so we've gone past time. There is one more question, and I would assume that the moderator would like us to stop now. I hate to get between people and their lunch. So I'll turn it over to you. And any other questions can be addressed this afternoon, I guess, in the session this afternoon.
Perfect. Thank you so much.